to have Dr. Madhukar Pai amongst us today to deliver his guest lecture on tuberculosis to us. Most of us know Dr. Madhukar Pai. We know him, I think, since 2014. I still remember the first lecture Dr. Madhu gave was on the gene expert. And today when we took him to the lab, he was so happy to see how we are repurposing it for so many other things, besides tuberculosis. I also had the pleasure of working with one of Dr. Madhu's students, Malden Nash, on HIV project, again on gene expert, and that was also a very, very fruitful association, I must say. We had a co-publication in Lancet Global Health with that small project that Maddie did with us here. Dr. Madhukar Pai was also associated with the MAC-ID of Manipal, and that was such a nice association. It's still going on good with a lot of support from the university. And some of us from the audience had the really good opportunity to visit Canada for the summer school, and we both were discussing how COVID put a stop to our visits to Canada, because after that it became an online program, and the advantage is that more people can log in from our university and we can attend the summer school virtually. But nothing like actually going and experiencing it firsthand in Canada, in McGill. The talks there are, it's really very good and very, very much applicable to what we are doing here, and we have a lot of take-home messages when we attend these kind of conferences. Dr. Madhukar lives TB, breathes TB, and most of his work is on the subject of tuberculosis. It's varied and it's humongous, I must say. And with his inputs, with his publications, and with his expertise, not only India, many, many countries have benefited in policy decisions regarding tuberculosis, not only in treatment, in so many other TB control matters as well as diagnostics. He has more than 350 papers to his credit, and we have heard Dr. Madhukar in multiple forums, wherever, even his online talks, but it's such a pleasure that, every time he talks, there's something, each talk is different, and there's so much new variety he adds to each of his lectures. I heartfully welcome you all, and I heartfully welcome Dr. Madhukar Pai today for delivering his lecture on transforming TB diagnosis. I'd like to invite Dr. Sevita, who will introduce the speaker to you and his varied work. Thank you.
You just introduced me.
No. And Madhukar was so humble. He said, no, I'm not going to send you anything about me. What is there to speak? I said, many of us know you, but there will be a small, few whom we have to tell the, the great work that he does. So, here goes Sevita.
Good morning. I consider it my privilege to introduce our guest speaker of the day, Dr. Madhukar Pai. Professor Madhukar Pai is a Canada Research Chair in Epidemiology and Global Health at the McGill University, Montreal. He is the Associate Director of the McGill International TB Centre. Dr. Madhukar Pai did his medical training and community medicine residency in CMC Vellore, India. He completed his PhD in epidemiology at UC Berkeley and postdoctoral fellowship at the UCSF. Dr. Madhukar Pai serves on the WHO Strategic and Technical Advisory Group for TB in the Southeast Asia region and the WHO Advisory Group on Tuberculosis Diagnostics and Laboratory. He is a member of the Scientific Advisory Committee of FIND Geneva. He serves as the chair of Public-Private Mix Working Group of the Stop TB Partnership. He serves on the editorial boards of Lancet Infectious Diseases, PLOS Medicine and PMJ Global Health, among others. He is the editor-in-chief of PLOS Global Public Health. We request Sir to deliver the guest lecture on transforming TB diagnosis.
Good afternoon, everyone, and thank you so much for the opportunity, and really lovely to see so many familiar faces again. Really sad that the pandemic really put a serious break on our McGill Manipal collaborations and the faculty and student exchanges we were doing. I'm still glad that a lot of your faculty and students are participating online in our summer program, but not able to come here or send my students here has been a big disappointment for me. But like Shrikala said, it's time to revive the collaborations. So I have no financial or any kind of industry conflicts to disclose, but I do serve on, as an advisor to many non-profit organizations. So the thing about TB is, if you had told me, say, 10, 15 years ago, that we would now have a 1-month regimen for latent TB, we would have a 6-month oral regimen for DRTB, I would have said it's a miracle, right? And those miracles have come true. We genuinely now have 1-month regimens, 4-month regimen. You can treat a child with non-severe TB today with just 4 months. You can treat a DRTB patient today, 6 months, no injections, all oral with a 90% cure rate. That's just incredible progress, all within the last 10 years or so, right? So treatments are getting better and better and better and shorter and shorter, but diagnosis is still a massive issue, even today. And it's gotten so bad during the pandemic. In fact, we wrote a paper on how devastating the pandemic has been for TB. Dr. Suchitra told me that even though you were doing thousands of COVID PCRs, you still kept other testing going. That wasn't the case globally. In most places, TB testing just vanished because of lockdowns, restrictions, diversion of staff and labs. I mean, all the machines were starting to run COVID PCR, so who will run TB tests anymore? So worldwide, we saw a big dip in case notifications. That means lots of transmission has been happening in the community. We were simply not detecting TB. And so the WHO estimated for the first time in many, many years, TB incidence and TB mortality have increased rather than decreased. So our ability to end TB by 2030 has really taken a beating because of the pandemic and the implications. And diagnosis is huge. Look at the gap here of what we call the missing. Out of the 10.6 million people estimated to develop TB in 2021, only 6.4 were detected and notified, which leaves a gap of 4 million people. And we don't know quite what is happening to them. Have they been diagnosed? Have they been put on adequate treatment? It's really unclear. So that's where we are, the biggest gaps. And even among those notified, barely 38% received the WHO-approved rapid molecular test. Most were still diagnosed based on smear microscopy, and good number were treated empirically. Look at the bacteriological confirmed TB, that was only 63%, right? A lot of TB is still being managed clinically based on doctor's opinion, x-rays, and so on and so forth, but not microbiologically confirmed. And if there's no microbiological confirmation, there is no drug resistance. We don't even know whether we're treating them correctly with the right regimens. Really disappointing to see this scenario in the current. And there's lots of reasons why diagnosis continues to be the Achilles heel of TB. And here is one example. In India, these are all studies from Delhi, Mumbai, and Tamil Nadu. An average TB patient takes about 3 visits to 3 different people, or three multiple visits, and about 2 months before TB gets diagnosed and put on treatment. And the fact that the same drama is played out in multiple cities in India tells me that this is the norm rather than the exception. You never have straightforward diagnosis of TB. It's always going to here, there, public, start with private, then go to public, start with public, then go to private, start with pharmacies, go to informal providers. This bouncing around of people is absolutely true and happening all the time, during which transmission is happening. And that is why, even if we diagnose and treat TB, the amount of time it takes to diagnose and TB means the chain of transmission is kept alive in the community. Very well-known phenomenon, okay? The next thing is private health sector is a huge reason why we have so many quote-unquote missing TB. It's not that we don't know there is TB, but they are in the private sector and not getting notified. They're being managed by all sorts of providers in the community, And that's a beautiful correlation. If you look at proportion of private care seeking and percentage of missing TB, there's a very nice correlation. Any country that has a lot of private sector is also saying lots of cases are missing. So missing then means some of them are genuinely being managed by the private sector. We have no idea what's going on, right? The government has made notification mandatory, but it's not really happening in practice. Next, quality of care. If you look at cascade of care, which is a beautiful way of understanding quality of care, the first bar is number of expected cases of TB. Second bar is number diagnosed to have TB. Next bar is treatment started. Next bar is treatment completed. Right? You can see the drop-offs happening at every level. This cascade of care model is very popular in HIV, and now we are starting to routinely do it for TB. It is being used for diabetes, heart disease. You can use it for any condition you want. It's a lovely management tool which allows you to say what is the overall cascade completion and where is the biggest drop-off or leak happening in the cascade. You can see in TB, whether it's drug-sensitive TB or drug-resistant TB, diagnosis is the biggest drop-off. We simply are not picking up TB at all. Once we pick up TB, generally treatment is started, and once we start TB treatment, generally most people are able to manage it, but we're simply not able to detect. And guess what? It's exactly the same for diabetes in India. Most diabetics in India don't even know they're diabetic. It is just not being able to detect that's a problem, right? So those of you working in diagnostics, you have a lot of work to do to make diagnostics more accessible and affordable and more community-based, just like what we did for COVID, right? For COVID, we did not wait. We took diagnostics into people's homes. It is that philosophy we need to bring to diabetes testing, or heart disease, or COVID, or TB, or malaria. Take testing away from large, centralized Cadillac laboratories into homes of people and schools and workplaces to bridge this diagnostic gap. We've also done some interesting work on how clinicians behave when they see people with suspected tuberculosis. We use the technique called standardized patients, which if you have a simulation center here, you would know. In Sim Center, we hire trained actors to portray various scenarios. So we've used that for tuberculosis, we've used it for multiple diseases, and we've now done simulated patient studies in 6 countries: India, China, Kenya, Nigeria, South Africa, and Indonesia. Essentially, we train somebody from the community to walk into a clinic and say, I have this chronic cough and fever. And then they just wait. They'll see what happens. If the doctor asks, how many weeks? 2 to 3 weeks. Symptom, yes. Weight loss, yes. Loss of appetite, yes. So in short, this is a textbook description of suspected tuberculosis. Right? Every known sign symptom is present in this case. And based on a huge amount of literature published, this is what happens when someone with suspected tuberculosis walks into clinics in 6 different countries. Barely a third of them are correctly managed. Okay? Not even 1 in 3 of classic walking, talking suspected tuberculosis is correctly managed across these countries, which is a huge issue as far as I'm concerned. And guess what? Most practitioners did all over the world. Medicines, tons of medicines. Everybody walked away with multiple medicines. A cough syrup, bronchodilator, sometimes a steroid, and of course antibiotics. Broad spectrum antibiotics, right? So in short, if you ask me what is the most popular test for tuberculosis in primary care in multiple countries, the answer is antibiotics. Failed antibiotics, multiple failed antibiotic treatments is how primary care providers make decisions. Their first response is not to think about testing. And this is true across all diseases, by the way. It doesn't even matter what you have. Their first response is, we're going to hit you with a bunch of medicines. And if it disappears, great, we're all done, case closed. If you still have a problem, you come back to me, then I'll figure out what you have. Right? We talk about test and treat, but in primary care, it is treat, then test, maybe. Even that is not guaranteed. Okay? This is why we have so much antibiotic abuse in this country. Not just in this country, in every country in the world. And I know that some of you are working on antimicrobial stewardship. I hope you all know how astronomical India's antibiotic usage is. World number one. India is world number one in many things, but antibiotic use is one among them. And India's antibiotic use absolutely skyrocketed during the pandemic. All of us know the whole azithromycin, doxycycline, ivermectin, hydroxychloroquine. The amount of antimicrobials that we threw around is just staggering. And we've done the analysis. We looked at drug sales. We published it. It is astronomical amount of antibiotics being used. How do you bring some rationality to this? Is a question that all of you should be asking, right? If you're completely bypassing the diagnostic step, you're just spraying medicines around and you're hoping things are going to get better. And it's going to create a massive problem in the coming years if we don't worry about it now. So we do have some great tools compared to the tools that I'm sure Shrikala and Suchitra and me, we would have all seen this in the past. How many of you have still seen those LJ slants? Remember those LJ slants? Most of them don't know. Which is great. It's still a museum piece now, right? Lowenstein Jensen. I could not even spell the Lowenstein properly and Jensen properly. But that's the stuff that we had, and that's the stuff you have today. Anyone today, including your lab, can walk in and access some amazing technologies that are available for TB. So if you ask me, am I happy? I'm very happy. What I'm worried about is that we're underusing them, right? It's not, I don't think lack of innovation is the real problem with TB today, both in medicines and in diagnostics. So how can we narrow the diagnostic gap? So this is a paper we published in Nature along with Dr. Soumya Swaminathan and Puneet Duwan, and it's open access for you. Please read it. It's easy to find. And we said in 2023, if we want to transform TB diagnosis, we can. It's absolutely within our grasp. And we offered 7 critical transitions that must happen in order to close this massive diagnostic gap. Okay, let me walk you through each transition very quickly, and then I want to give enough time for Q&A. First transition, in 2023, there is zero reason to mess around with smear microscopy. Don't get me wrong, I have nothing against the humble microscope, but I don't want to even see it for TB anymore, right? Do you really think we could not have, we could have managed COVID? Look at the billions of PCR we did for COVID, billions. Why are we then not accessing those sorts of technology and still messing around with that microscope, which is barely 50% sensitive, can never detect drug resistance, and it is simply not a technology that is appropriate for today. It was okay 50 years ago, but today, to just only diagnose TB with microscopy, in my opinion, is simply not good enough. We are not trying, we know we can do better, we should be doing better. So the first big transition is I want to see smear microscopy dead and buried for initial diagnosis of TB. I want to see WHO approved rapid diagnostics. And there are so many. You yourself have a bunch of them sitting there. This is the most important critical transition you want to see. So if you see someone is really classic suspect of tuberculosis, go straight for a CP-NAT, TrueNAT, whatever you have, and get on with it. You get results the same day. You know what the drug resistance is, at least for rifampicin. You have a very smart way of treating that person. Okay, that's the first transition. And that's exactly what WHO is saying. This is a brand new diagnostic standard published by WHO this year in 2023. Look at what it says. In all facilities, in all districts, the TB diagnostic algorithm requires the use of a WRD. WRD means WHO approved rapid diagnostic, right? Molecular test. As the initial test for all individuals with presumed TB. Not just confirmed TB, presumed TB. Upfront CB-NAT molecular testing is what the WHO is now pushing for. And this is no different, in my opinion, when people working in HIV/AIDS will tell you, for a long time they were using CD4 counts, right? Then they decided it is simply not good enough for us. We need better, we need viral loads. Overnight, they made a policy change. They ruthlessly stuck to it. everybody abandoned CD4 made viral loads happen. Is that not true, Deepak? Why is it that we can't do it for TB? The ambition in the HIV community was so high, they wanted viral loads to know whether ARVs were working or not, and they made it happen, right? In TB, we're still messing around with a microscope, including this country. There is zero reason why we can't pull this off. None at all. After seeing what India has done with COVID PCR, I am not willing to accept that there is no money, there is no technology, there is no smart people to run the test. All of that is an excuse, okay? We need to really do what people in HIV did, abandon an old, underperforming tool, migrate to the best in class tool, right? Next, this of course, some of you are going to be unhappy with this, especially those who love centralized big labs, like the Cadillac lab that I visited this morning. I'm looking at Suchitra. I don't have any problem with your Cadillac systems, okay? But you've got to also find ways to move molecular testing into primary care. That is the next frontier of point of care molecular testing. And it is not either or, okay? You need the high throughput systems that you have. You need to move your samples and centralize, because sometimes that's the most economic model. But sometimes this centralized testing does fail people because it's not close enough to them. So find technologies that will let you move it at least to the PHC level. I would love to see PHC in India having a better suite of diagnostics for common diseases, right? Essential diagnostics that you need to deliver at the PHC level, because everything does not need to come up to the district level or to the tertiary care level. So we are hoping that there will be more innovations in point of care and molecular testing. How many of you have seen or done molecular testing for COVID at home? So there are tests now, and I have done it at home. I was just blown away. I could sit in my home in my pajamas and do a molecular testing, single-use, disposable. I'm like, this is bonkers innovation. COVID really opened the doors. There are now tests that you can use for home, molecular, for COVID and flu. One shot, right? Do a swab, put it in, click the thing, and it goes green or blue and red, and you're done. That's molecular. It's actually a PCR in a single disposable unit. That is the level of innovation that's happening. There's no reason why we can't be exploring that for tuberculosis. Third, and this absolutely you're already doing, and I saw it in action today, we stopped thinking in terms of this is a TB machine, this is a COVID machine. It doesn't matter, it's only a machine, right? Nobody sold it as a COVID machine. It is just a damn PCR system. So why don't we take every molecular system we have, find a way to see where is it, who has it, what diseases can it do, what is the throughput, where are the samples coming from, and do what is something called diagnostic network optimization. Now there is a whole handbook on how to do DNO, and if you want professional help on how to do a DNO, I can put you in touch with the right people. It's already happening across India. You need to really optimize every piece of molecular system you have in your region and say, okay, we have 18 systems, 2 gene experts, 3 TrueNAT, 6 bioMérieux, whatever. Find a way to harness them and then use them for all conditions that you need. You run COVID in the morning, you run viral loads in the afternoon, you do malaria on the side, do whatever you need to do. Squeeze all the juice out of your lab network. Never ever say this is only TB, nobody else can touch it. Those sorts of thinkings are completely passé now, right? Even Global Fund, which is TB, HIV, malaria, wants integration. They want to get more value out of their investment. So regardless of who bought the machine and what it was bought for, the entire network is yours to do multiple tests on them. And of course, there are panels being developed for respiratory panels, fever panel, diarrhea panel. That's another way to integrate testing. So that's exactly what we did. That's our paper in Lancet by Emily, who was supposed to do her thesis with you, but couldn't. But that's an example of how we use the same gene expert system with the with the COVID cartridge and a TB cartridge on the same sample, right? So one sample, 2 cartridges, we tried to do it, and we published it on how to successfully integrate COVID and TB testing. So we have to find ways of integrating multiple testing. So if there is a flu-like pandemic or illness going on, you can integrate multiple testing and successfully do it with that. And then the fourth transition we are talking about is the need for much more simpler samples than sputum, right? Sputum, many people with TB simply cannot produce a good sputum, and even if they do, it's more saliva than it is sputum, right? The quality of sputum is poor. Of course, kids can't produce sputum. People with HIV disease often cannot produce sputum. Extrapulmonary TB is gone. Sputum has limits. So there are now a whole amount of work happening. One is the urine lamp and urine-based testing and higher sensitivity urine tests. Everybody can get a urine sample. We can do what's called as a tongue swab, scraping the back of the tongue, and the amount of coating it happens. So whenever we cough, there's some coating of NTB on the tongue swab. People are also looking at mask sampling, right? You wear a mask and you breathe in, breathe out. That condensate can also be used. And tongue swabs are starting to look very promising. I encourage you to validate those innovative samples combined with CT-MAC as a backend. And then of course we learned that good number of people are simply not seeking care. They have TB, we know that from the prevalence survey, right? All these are prevalence surveys. And in all the prevalence surveys across the world, they find that even among microbiologically confirmed cases, only half report symptoms. So the other half are having TB, not having much symptoms, not seeking care. And we call that phenotype subclinical TB, right? Subclinical disease. It's only because of X-rays that they could even be picked up. Without X-rays, they would have never been missed. So if you just rely on 2 weeks of cough, we would have missed a lot of TB. And so people are saying, let's go find them in the community, right? Let's do what's called active case finding rather than waiting for them to come and knock on our doors. And then lastly, the big transition we are hoping is not just worry about sensitivity and specificity of a test, which is clearly important, but also look at the ability to reach a large proportion of the population. We call that a population diagnostic yield. Beautiful example is COVID rapid tests, right? I remember when COVID rapid tests were introduced, all the purists were very unhappy. They said, yes, this is not sensitive enough compared to PCR. We said, it may not be sensitive compared to PCR, but it can reach millions more people than your PCR can. Because suddenly we now have it at home, we can run it in school, we can run it in the airport, we can run it in the waiting area, we can do crazy things with it. So yes, rapid tests for COVID are less sensitive, but the coverage of the population was massive. And therefore, the population level yield is still very high. It is this thinking that we also want to bring for tuberculosis. If we waited for the perfect sensitivity and specificity, we will not reach the big scale that we're looking for. Same thing has also been true for HIV self-test. When HIV self-test was first introduced, the purists said it's not good enough, the sensitivity, as your classic laboratory test. But then they said a lot of people with HIV are not even wanting to get tested. They should have the privacy of the test at home, like a home pregnancy test. And then it got approved. Now lots of people are testing themselves for HIV. We want to move towards the future so we can do more and more testing at home and non-medical settings as we can. And lastly, we genuinely believe that time has arrived, learning from COVID. I mean, honestly, if India had not manufactured its own COVID vaccines, this place would have looked devastated, even more than it really was, right? We've learned very big lessons in the COVID. Waiting for donations from rich countries is a bad idea. One must be self-reliant, and India led the way on self-reliance, right? And learning from India and China and other countries that manufacture their own vaccine, all of global south, and that's India's G20 push, by the way, right? More and more manufacturing of products in low and middle income countries. Not just vaccines, diagnostics, medicines. India is already a pharmacy for the world in terms of generics. India is also an emerging power now in diagnostics, which makes me really happy. You need more domestically manufactured product. I'm not nothing against good products from elsewhere, but having them at more affordable cost greater scalability, and products that are more rugged and designed for our environment, right? Our crazy power cuts, our temperature, our humidity, our dust, all of those are relevant. So, my last slide is really how do we take advantage of this? There are two big things that are happening now. Every country is working on pandemic preparedness, right? The pandemic agenda is right in the front of all our political leaders. There's also a big push for universal health coverage, right? And both of them are good because we can learn from both. So we've written a lot of pieces saying that let's please squeeze TB into the pandemic agenda, right? TB by itself never gets political attention. It's simply not resonating with anyone. But if we can sneak it into the pandemic preparedness agenda, we can get much more done, right? For example, how many amazing trackers and apps were innovated around COVID? How many such apps are there for TB? Virtually none, right? We can take these and reconvert them and repurpose them for tuberculosis. That's one thing we can do. Look at all the innovations happening around imaging. Unbelievable innovation. Imaging is now a super advanced area. Not just imaging, amazing AI solutions, right? We were talking about AI this morning. There is an Indian-made, two Indian-made AI companies that have already put out. One of them is WHO approved, Cure AI. That's a completely India-made handheld X-ray device. Amazing stuff that's happening in this area. There's no reason at all why these should not be taken and adapted for TB to advance imaging. I mean, point of care ultrasound is so advanced now. I mean, you can literally run around the hospital with your own handheld thing that you hook up to your iPhone and you're ready to go. And then cough, AI is another area. There is now like a Fitbit for cough, right? The cough sounds are detected by the apps like Shazam, right? You can detect that. It's already on the iStore, Google's Android store. Shazam for cough. And we are working in this area. We want to know whether cough sounds, the algorithm can say this is more a TB-like cough, this is more a COVID-like cough, this is a smoker's cough. It's been 2 weeks now, you've been coughing, Shrikala. Can you go check yourself out, right? So Shrikala gets a message on her WhatsApp. You have been coughing for too long. Your lab is right next door. Get that gene expert test done. But you know, every one of us ignores cough, right? Have you noticed? We are the worst people in the world. What the heck? My phone is listening to me. Speaking of AI. Okay. And then, of course, what magnificent innovations happened around COVID testing, right? Never seen anything like that. We realized very soon that we need more decentralized solutions. We really, that's the test that I did at home, that little disposable molecular test. Vending machines with COVID tests, parking lots, right? We drive through COVID tests, card tests, PCRs, integrated tests, and we simplified the samples. We realized the deep nasopharyngeal swab, remember that painful thing? I hated it. I absolutely hated it. So the minute they said, oh, an anterior nasal swab is good enough, like I'm done. I'm never getting that deep swab again in my whole life, right? So we found ways to creatively make testing easier and scalable and more decentralizable and closer to people's homes, you know, where they are studying, where they're working. That is the philosophy we need to bring across all diseases. Why should everything require people to waste half a day of their life going and waiting for the test to come and results come 2 days later? There are ways to really simplify diagnostic testing. And sequencing, I was just saying, you really need to get into sequencing. I mean, look at the expansion of sequencing capacity in Africa region. They really used this pandemic to explode their ability to sequence. And WHO just approved targeted next generation sequencing for drug-resistant TB. You already have sequencing for COVID variants, a whole bunch of virology and other reasons. And for cancer, sequencing is not just infectious diseases. So find ways, as the cost of sequencing is dropping by every passing year, sequencing should become part of our personalized medicine toolkit, and we can really do well. Like bedaquiline, we don't have a good DST right now. Sequencing will become the product of choice for new drugs like bedaquiline and recombinant, for which we don't have a molecular test yet. And lastly, the UHC agenda has really pushed people. So WHO published an essential diagnostics list. India has a national essential diagnostics list. I hope you all know that. Nigeria has its own essential diagnostics list. Just like every country has an essential medicines list, there's now an essential diagnostics list. And we are hoping that this will allow us to get TB and other essential tests into that, and then the government will pay through the universal healthcare program like Ayushman Bharat or other insurance programs. So lastly, I think my appeal to all of you is that please upgrade your practice. You today have the shortest regimens possible for TB. You have magnificent molecular testing available at your disposal for TB. Please use them for people with TB. There is no reason to stick to smear microscopy, 24-month injectable regimen. That is simply not good enough in 2023. And if you and I had a DRTB, not one of us will agree to be on 24 months. I would not, right? I simply would not accept that as good enough for me. So why would we do that for people with tuberculosis? Thank you so much for your time. I'm happy to take questions.
Thank you, Dr. Madhukar Pai. We are actually having a big group of public health, microbiologists and clinicians who are assembled here today. And I'm so happy that I can see so many of them are really interested in tuberculosis. I think we should be having one group of people who are going to work together. And if anybody is having any questions to Dr. Madhukar Pai, please feel free.
I wanted to ask just a couple of questions. One is, you spoke about those simulated patients, right? Sounded so interesting. What was the sample size actually like, to come to those conclusions?
So in India, we did something like 2,000 interactions. So it's more that the same simulated patients can do 50 different doctors in that day, right? So you can ratchet up the interactions very fast and easily, but training them is the key. Extensive training. And then they have to remember everything that was said to them, done to them. They have to bring out the prescriptions, and they have to code the prescriptions. There's a lot of background work.
So 2,000 means 2,000 doctors were...
No, 2,000 interactions.
Oh, okay.
Consultations.
Consultations.
That's the sample size unit.
And you said like the future rests on, like say testing samples at home, So how does reporting go then? Somebody may just test and, just keep quiet about it. So in a country like ours, I don't know whether it will actually help the program or whether it will derail it somewhere. I don't know.
No, I understand the anxieties there, but I feel like empowering people to check themselves and then seek care is much better than the current system of a lot of people simply not able to seek care, right? So I see that even self-awareness itself is very good, right? If you are aware you're diabetic, great. You may not even go to someone necessarily. If you can do something about it, then, like just as we are being told by our watch that we're not walking much, right? A step count is horrible. I know this is a problem for every one of us. Self-awareness is even the first step. When I started wearing a Fitbit, the biggest thing it did to me was it told me I am dramatically under-exercising. By any metric, I was like horrible, and that awareness motivated me, changed me, and since then I've never looked back, right? So I think it's just the first step is knowing. If I knew I was diabetic, I know I'm pre-diabetic by the way, and that awareness totally changed me. I'm now on metformin for pre-diabetes. I'm working at it, right? Awareness is the first step and the biggest step in my opinion. If we can get that in, then I have a feeling people will head on the right path.
I think I agree with you because the HIV testing is so well done even at the PLC level.
Yes.
So the awareness is not only in the population but also the treating physicians who are asking for it. So there's already a network which is built not only in case of HIV but also in case of tuberculosis program. And just to say now, our government is going towards CP9 as the first test, and microscopy, we hardly get samples for microscopy now. And to reach the nearest people, because CP9, as you said, these are equipments which will cost. So what government is doing now is just to the rest of the people, and they have reached out to the medical colleges which are already having these equipments, and they give us the cartridges and they give a nominal amount for us to conduct. So instead of doing the microscopy, the first test which is done now is CBNAT.
That's
So,
amazing.
yes.
Truly amazing. And it's a
Because
nice
in
example
COVID, in
of
COVID,
government.
most of the medical colleges were actually forced to buy the
Molecular
molecular.
platform.
So it's just like repurposing what is already there in the system.
Absolutely.
So I think it's a really good idea.
I mean, the explosion of molecular platforms during COVID, what are we going to do with all of that? It's there, right? It's sitting there and idle. We've got to find ways to use it for a variety of conditions, right? Communicable and non-communicable. So another area where I think self-testing would be extremely important is women's reproductive health. There's still a lot of stigma around it, like home-based HPV or pap testing, right, for STIs. Anything where I think stigma prevents people from coming and seeking care. I think home pregnancy test has been around for decades, right? We got to think of the same type of model to kind of make testing less stigmatized and more easily accessible for vulnerable groups.
Any other questions?
When I went to your paper, there is a sentence telling that India has already started this transforming ways. Can you tell us what's happening in India?
So I think, like Dr. Suchitra said, if you look at the Government of India's TB report, recent TB report, the algorithm for suspected TB starts with CP. So on paper, India has already agreed that molecular testing should be the #1 test for TB. Where I think the problem is procurement and reaching scale, right? And I think more and more of the nationally manufactured TrueNAT is starting to get scaled up because it got scaled up during COVID. There are many more products coming out of India as well now, right? There are many more molecular companies in India. So finding ways to tap into all of them could be extremely useful, I think, for India. I'm also aware that India is starting to adopt the 6-month DRTB regimen and the 3HP regimen for latent TB, right? So India is starting to adopt all of this. What I want to see is the numbers, reach the numbers that it needs to. Because with India, it's always a volume issue. The numbers are enormous here. Scale is what really should drive us, right? Having it is not enough. Anybody has it, right? If 2 people got the DRTB regimen for 6 months, for India, that's no scale, right? You need good proportion of people with India DRTB benefit.
So CBNAT, as you said, can be taken up, but the issue is there are white elephants.
I know.
Even slight fluctuation when the machine is running, the whole test is gone. So it requires a lot of work to be done, or we have to go to the rapid test like we have done for COVID testing, we went for antigen testing, etc. Something simpler like that will be more of use than
That's the
only
dream.
about the
A simple rapid test for TB would be the dream. The urine lamb was the one that was coming close to it. There was an advanced 2nd generation lamb. Unfortunately, it did not do well in trials. So it's kind of only for sick people with HIV at this stage. But we are hoping that something like a tongue scraping combined with an affordable map. The other potential cost lowering would be an open PCR kit that can run on any molecular platform, no matter who has it, what is there. At least if that is standardized and it's more affordable, at least you can get MTB plus minus result from a rapid test. And then if it's TB, then maybe you can do DST later on, right? That would be very good.
So what's your call on IDRA regarding latent tuberculosis for a country like India?
Again, India is not a poor country anymore. So if you wanted to diagnose latent TB with IGRA and then start people on 3HP, that's already happening in India, right? It's already started. Again, it's not large scale right now, but it's possible. If you want, and if IGRA is still too expensive for you, then the CTB skin test, the new skin test by SSI, has the same antigens essentially. And it should give you similar performance, but you need to do a good job of the procedure. Like MAN2, I don't know how much MAN2 skill is still left in the country.
Still being used,
Still
most
being
of them
used.
are ophthalmologists they do still make use of it. No, but when we are talking about IGRA is with a place like ours where we are literally having 50% of the tuberculosis in our country, and we are talking about latent tuberculosis. How good can we make use of IGRA?
So again, in India, I would be very careful in targeting the right set of groups to do preventive therapy. So undoubtedly, and Deepak and others here will know, people with HIV have the highest risk of progressing to TB. No questions asked, right? They are like really the most vulnerable group, and testing them and treating them is a great area. No questions, no confusion, very clear. Children under the age of 5, as clear as it can be. No child under the age of 5 has any business to have TB infection, right? That means they've all been recently infected because they're only 3 or 4 or 5 years old, and then they tolerate medicines beautifully, they are worth treating. Now the government saying and WHO saying all household contacts, right? Again, if their family is keen and they are willing to stick with the regimen, this is no problem at all in offering them that option.
Might it give rise to like drug resistance?
No. This has been looked at by any number of studies. Nothing bad is being reported at. No. So I would confidently say for these groups, close contacts, and people with there are other immunocompromising conditions, right? People on chronic kidney failure, right? On any group that you are really scared of, right? On seriously, dangerous, toxic immunocompromising medicines. I think testing it for the DIGRA, if positive, the 3-month regimen is very doable today. Earlier it used to be 69 months of isoniazid, which was very hard for people to take. Because if you're not feeling sick, you're not going to stick with it, right? So that I think the 1 HP regimen will probably become the standard in the coming years, depending on WHO policy updates. That might be phenomenal. Imagine 1 month, 4 doses once a week in adult, right? Anything we can do to reduce. The dream would be a single shot treatment for latent infection. 1 dose, done, go home would be very, very helpful.
But with the kind of infection rate which is there here, would it be sufficient that you do IGRA, you treat, you're going to get exposed again?
But generally, we've not seen a need to continue therapy again and again or lifelong. The only exception is groups like minors. In minors in South Africa, they found, especially with HIV that they have in South Africa, if you just give short-term preventive therapy, they get infected again and they develop disease. But in our scenario, HIV is not a driving issue here, right? So I would predict that one-time treatment should be adequate. Any other questions? Deepak?
Just 2 or 3 quick points. It's always nice to hear you. The same energy which we heard somewhere in 2018, you still have the same energy, which I think it should be infectious. We should say that energy. Whenever we listen to your talk, we feel super motivated. And when we go to the clinical stuff, slow and motivation comes. The second part, what you told from physician's point of view, I don't remember asking for sputum AFT. Now to the government, gene expertise, or they call it CBNet, it's free of cost. So majority of our sample goes to the government. Because if we send to our lab, the cost maybe 2,000, that's
That comes to our lab.
Again,
From the government, it comes back to our lab.
That's fair enough, but it's free for the patient. So what we do is we make use of our TB program.
Very nice.
Where they have changed from convention, I was just seeing that. There is gene expert, then there is LP also, line progressing. So your first point, I think India has taken care of, and rarely I have faced that there is no cartridge, nothing like that happens.
But Deepak, that's because you are in a good state.
Yes.
I would not generalize this to the rest of India. The rest of India is not doing well necessarily, but you're lucky. I think the southern states are really acting on it. I'm very inspired by what you told me. The government is giving you cartridges plus a little bit of money. Maybe, Bobby, this is the kind of story that's worth writing. A model where people are getting upfront CB-NAT thanks to the extra infusion from the government is a great story worth writing, I think.
It comes to their lab. So that diagnosis part, if they come to it, especially in Mangalore, that is taken care of. so that we know whether it is sensitive or not.
Beautiful. Beautiful.
And same thing, in our HIV program also, it is encouraged. The government has sent a circular. If any cough, please use premium. So even if you go to HIV clinic, they will refer to that. So there is a good amount of understanding between the HIV program and the TB program. And even in our HIV cohort, if I send my patient to start ART, first 6 months INH prophylaxis is given. Because that is where the highest chance of getting TB.
Okay.
As Madam talked of resistance, we are using that in our government cohort. So the one tablet of INH is given for 6 months.
What about 3HP? Can you get access to that?
No, that we have not started. As per the government, now only it's INH. I am talking of PLHIV. Once we start them on ART, 6 months of isoniazid.
But there is mono-resistance to INH.
Yeah, but when that may be at individual matter, but at a large, when we run at a program level, this is working out very well. What they do is they ask the simple symptoms: fever, cough, weight loss, night sweat, which is there is no investigation at all. If answer to all this is he is a candidate for IPT and 6 months is given. So that part, which sir told, that is also taken care of. So these are the two things that has changed from when we started using the.
What about the bedaquiline containing 6 months for DRT? Do you have access?
No, we don't deal much with drug resistance. So what if we find out, we refer them to the government and assume
they go into the PMDD program.
Yes, they go into that program. And
No, I think once we start making use of LPA for most of the patients, we'll be able to detect, because at present what we are doing is only the drug resistance, what we are telling you is only concerning the CBNAT, which is rifampicin resistance. So we are not able to pick many of them, because when we are trying to validate our LPA, we find that there are other kinds of resistance. I think once LPA is made available to most of them, I think we'll be able to know the real rate of resistance.
Even in the national program, they have LPA. They have it's a part of the flow.
So now, the CBNAT, the government is actually asking us to start LPA, and they want to have the PPV model again with LPA. Because we've just started now, but there's already people from the state board are trying to contact us and say that validate your lab so that you can come on board for LPA. So that will be much faster, because for the entire Dakshina Kannada it is going to Hubli for testing. So they have to wait for 5 to 6 days before they get the result. But if we come on board, it will be 48.
But you have widget DST, right?
No.
Oh, you
We are
don't.
only having cultures. We don't have DST.
Only have solid.
Yeah, because you require to have a DSL-free facility to start DST. So
Which you have now.
now we are having. So we are progressing, but what the government is encouraging us to go towards LPA more than the DST, because it will take more time. They want us to start LPA and go on board much faster. That's the encouragement that we are getting from the government.
Any other questions, comments?
What is the percentage of children having TB in India?
There isn't great data on that, but what I can tell you is there was a big, wonderful project in Delhi by FIND and Indian government and Pediatrics Association. They started doing routinely gene expert for children, and they found a very high prevalence of TB in children, and also prevalence of DRTB in children. See, you never think of children having drug resistance, right? It's only when they did gene expert, they even detected it, which tells me there's a lot of undiagnosed pediatric TB in this country, right? So I think aggressively testing children with molecular testing, and you can use multiple samples now. So you can do nasogastric aspirate for young children. For slightly older kids, you can do induced sputum if it's possible, and you can use stool. Stool X Gene Expert is also an option that's approved. There's a specialized processing kit that you need that is available for you. So you can use a variety of samples, and extrapulmonary Gene Expert works beautifully with lymph nodes, less so with pleural fluid, but works quite well with CSF. Oh my God, it's beautiful. If you suspect TB meningitis, there is only one test, Gene Expert on CSF.
Thanks a lot, Madhu, again, great presentation. I just wanted to quickly say that the government of India's India TB report 2022 and 2023, if you look at it, the percentage of microscopy is only dipped by less than 1%. Like it's I think 78 and now it's 70. 7 point something.
Yeah.
So a lot more needs to be done, right? This is
Yeah.
so some states like southern states or Andhra, for instance, they have tipped the balance. They're doing more molecular tests than microscope.
Correct.
But there are many states where the microscopy molecular test uses like 7 or 9%, like Gujarat, etc. So like, it's not the machines, right? It's not the
It's
resource.
not the
There's
machine.
so much of
There are
money.
lots of PCR systems.
Yeah, now we have
It's
lots
one is
of
the cartridge prices are still high for the program, right? So they genuinely have some budgetary issues, and I hope that the cartridge price will go down. I want to see more products, Indian products, compete in this market so that they can reduce the price. That generic PCR kit
Yeah, that's what
that
we
can
have
run on
the
any
open
platform.
system, yeah,
That open system might really be the next frontier on making it more affordable. While we come up with something like a dipstick, that would be the dream, right? Then we won't worry about this, we can really rescale. But for now, I think we need to advocate for greater and greater investment in this area. Because I still think diagnosis is the biggest weak link in India. Once TB is picked up, generally the system is doing well, right? And then of course we can adopt interventions like food baskets and nutritional work that Anurag and Madhavi have so beautifully. Please invite Anurag and Madhavi here to speak about their amazing trial results. It's all over the news and they are right here in Mangalore.
I spoke to him and congratulated him.
Exactly. So he would be delighted. So I think that model is now being looked at in other states on how to scale it up. Because if you can prevent TB, then much of this, in the absence of a good vaccine, what do we have right now, right? We don't have a good vaccine. Phase 3 trials are just starting. So I think food is the best vaccine we can offer right now, right? And then while we wait for a silver bullet vaccine to come by, we have something doable right now.
So what's your take on TB Mukt Bharat?
I'm hoping against hope that we will actually
Where are we?
invest. We are far away. We
You
are
know
far,
the ground reality, sir.
we are far away. We are far away. Yeah. So is every country right now. The pandemic has
Because
been
of the COVID.
quite devastating, right? So globally, the curve is all ticking up, and the projection is it has to worsen before it gets better. There is so much undiagnosed TB backlog from 2-3 years of the pandemic that we have to catch up on. So we have to work even harder
We
to
have
get to
to
where we.
Change the milestone.
We may have to relook the milestone depending on actual estimates that are coming in. This year would be, I think, an important year because would it still worsen? We don't know. Will it start dipping back? We don't know. I think most countries are catching up now or have caught up, but there'll still be a ripple effect from the backlog is what the modeling suggests. But we need to look at the actual numbers and then rethink what our trajectories are. Thanks everyone.
Just a quick question, what bedaquiline can we use? Can we test resistance using NPA?
No.
Not yet. There is no option right now. Sequencing could be an option. Sequencing could be.
Thank you, Dr. Madhukar Pai. I just request Dr. Rekha, which will be a privileged medicine, just give a token. And it was a token of gratitude from us. Thank you so much for making time.
Thank you, Dr. Madhukar Pai, for having come down and given us this. Like Dr. Deepak said, every time we hear him, we really get charged up. And I really hope, unlike what Dr. Deepak said, that the charge continues and we, take so many take homes from Dr. Madhukar's talk. And we hope to see you again in the near future. Dr. Rekha has given you one more opportunity to come, and I hope you can make it, for the national conference in public health. So thank you everybody for having come here from all your morning activities. So thanks a lot for it.